Good evening. My name is Sarah Ackerman, and I'm the director of the incredible Center for Digestive Health team at Virginia Mason Franciscan Health. It's my pleasure to welcome you to tonight's lecture. We host a lecture series yearly on a host of topics of digestive concerns. The Center for Digestive Health is comprised of a team of pathologists, gastroenterologists, surgeons, oncologists, endocrinologists, and radiologists who are looking to optimize care of the patient through our culture of quality, focus on access, innovations in research, and educating the next generation of caregivers. By emphasizing innovative and quality patient care, research, and education, we provide excellence in our areas of distinction, including the Center for Weight Management featuring bariatric surgery and medical weight loss, our Center for GI Cancer Prevention, and the care of esophageal, colon and rectal, liver, pancreas, and biliary disorders, as well as motility disorders. Education and research is embedded in everything we do in the Center for Digestive Health. And our multidisciplinary team is seeking to improve your health and well-being, teach the world about what we do best, translate cutting-edge research from lab to bedside, pursue quality initiatives to provide you that very best care, and discover innovations to transform your experience at Virginia Mason Franciscan Health. We've been doing this work for many, many decades, and since 1982, our national breakthroughs have impacted how we treat digestive concerns at the regional, national, and international levels. And while we feel that the Center for Digestive Health is very special, we have been honored to be awarded numerous accolades over the years, a reflection of the hard work of our providers and their dedication to their patients. Our presenters this evening are Dr. Misho Hupka and Dr. Rajesh Krishnamurthy. Dr. Misho Hupka obtained his medical degree from the University of Washington. He completed his surgical residency here at Virginia Mason, joining the general surgery group in 2010. He then completed a cardiothoracic surgery fellowship at the University of Washington, returning to Virginia Mason as surgical director of the Thoracic Center. Currently, Dr. Hupka serves as head of thoracic surgery, Deputy Chief of Surgery, and Medical Director of the Virginia Mason Cancer Center. Dr. Rajesh Krishnamurthy joined Virginia Mason in 2017. He completed his medical degree at Madras Medical College in Chennai, India, followed by residency at Wayne State University. He then completed a fellowship in gastroenterology and hepatology at the Mayo Clinic in Rochester, making his way to Virginia Mason for an advanced endoscopy fellowship. We're so fortunate that Dr. Krishnamurthy stayed on to serve as a therapeutic endoscopist here at Virginia Mason, where he focuses his research on GERD and Barrett's esophagus. We're so honored to have both Dr. Hupka and Dr. Krishnamurthy speaking this evening and look forward to engaging in discussion with them during our Q&A section following their presentations. Thank you so much.
Good evening. I'm Dr. Krishnamurthy. I'm a gastroenterologist at Virginia Mason Medical Center. This is the outline of today's talk. We are going to start with what is GERD, why should we treat GERD, what is the relationship between GERD and Barrett's esophagus and esophageal adenocarcinoma or esophageal cancer, how do you treat GERD if you have GERD, and if you decide to treat GERD with PPI medication or the purple pill or the Prilosec, is it safe for long-term use? What are the non-PPI management options for treatment of GERD, say if a patient does not want to take the PPI medications? Let's start with the first question, what is GERD? GERD was first described in 1935 in the medical journal called JAMA by Dr. Winkelstein from Mount Sinai in New York. So it was not described long time ago. It was just 1935. In fact, when it was first described, it was called as peptic esophagitis before it became popular in its current name as GERD, which stands for gastroesophageal reflux disease. What are the symptoms of GERD? There are broadly two categories, the typical symptoms and the atypical symptoms. The typical symptoms are the heartburn that you see on the TV advertisements and the regurgitation of food or acidic contents. Those are the two common or the typical symptoms. What are the atypical symptoms? This could range anywhere from chest pain, laryngitis or hoarseness of voice, or chronic cough, or even aspiration pneumonia. While we are on this topic, I want to specify a point about chest pain. Any chest pain should be considered, or any chest pain is cardiac chest pain unless it's been ruled out. So any patient that has chest pain, if they believe this is related to GERD and come to my clinic, I first tell them, let's make sure you see a cardiologist, it's not coming from your heart, and then I'm happy to take care of any esophagus or GERD related chest pain. And the laryngitis and hoarseness of voice, many times it becomes a turf war between is it an ENT problem or a GI problem. And many times you start with ENT and then they send the patients over to GI, or we can start in the GI and then sometimes send the patients over to the ENT side. The chronic cough tends to be occurring more in patients who have nocturnal GERD, meaning patients who have more reflux in nighttime tend to have the chronic cough, and they are the same people who are at risk of aspiration pneumonia, meaning they aspirate when they are lying down or sleeping from the stomach into their throat and into their lungs. What causes GERD? There are several mechanisms that lead to GERD, starting from the mouth all the way into the stomach. This could be one, impaired acid neutralization by saliva, meaning our saliva that's produced in the mouth helps neutralize the acid or the acidic pH. When there is a decrease in saliva production, that can lead to GERD. Number two, impaired esophageal motility. Esophagus is designed in such a way that it's constantly moving in a wave-like fashion and pushing food and other secretions into the stomach. If there is issues with this motility, where the esophagus is not able to clear its content in a timely fashion, that can set patients up for GERD. Number three, inappropriate relaxation of LES or lower esophageal sphincter. Basically, all of us have a valve or lower esophageal sphincter at the bottom of the food pipe that stops the acid and food contents from coming up into the esophagus from the stomach. When that sphincter does not do its job of being really tight, that sets up patients for getting reflux. And number four, hiatal hernia. What is hiatal hernia? When the top of the stomach squeezes from the abdominal cavity into the chest, that is called hiatal hernia. When that happens, the reinforcement of the lower esophageal sphincter or the valve by the diaphragm that's on the outside is compromised, and as a result, it's easy for acid and food contents to come into the food. And my colleague, Dr. Hupka, is going to talk a lot more about hiatal hernia and its management. Our next question is, what are the risk factors for GERD? Again, there are two categories, modifiable risk factors and non-modifiable risk factors. So the modifiable includes consumption of coffee or caffeine, chocolate, smoking and alcohol use, eating fatty and spicy food. Basically, anything that is good in life is bad for GERD. So it's easy to tell patients to stop these things, but it's hard to practice. And obesity is listed as a modifiable factor, but we all know it's easier said than done to lose weight. Yet, technically, it is a modifiable risk factor because you could lose weight. And moving on to the next category of non-modifiable risk factor, this is where the hiatal hernia is. Once you have a hiatal hernia, it's only going to get bigger over your lifetime, or it needs to be fixed, often with an endoscopic or a surgical procedure. Moving to our next question, why should GERD be treated? Why not just tough it out? This is the reason why we should treat GERD. To improve the quality of life, meaning you don't have to deal with the symptoms that's impairing you on a day-to-day basis. Number two, to prevent what is called Barrett's esophagus, which is a precancerous condition that sets up patients to develop esophageal cancer if their GERD is not treated. And number 3 is esophageal cancer. We're going to talk a little bit about Barrett's esophagus and esophageal cancer in the coming slides. So what is Barrett's esophagus? This picture illustrates what a normal GE junction or gastroesophageal junction that looks like when you take a look with a camera or an endoscope. So this area where the pink colored mucosa or pink colored lining joins with the salmon colored center or the orange colored center area, that's called the GE junction, or that's where the food pipe transforms or becomes the stomach. So the pink surface on the edges is the normal esophageal or food pipe lining. The center orange is the normal stomach lining, and this line that demarcates the two is called the Z line or GE junction. This is normal. When this picture starts to look like the picture on the right, that is called Barrett's esophagus. To zoom in a little bit more on this Barrett's esophagus picture, again, the pink lining in the edges, that's the normal mucosa or normal lining, and these orange or salmon colored tongues are called the Barrett's esophagus. That's the abnormal part. The same thing when you take a bite and look under the microscope, normal esophagus or food pipe will look like a stack of tiles, and with reflux that is non-controlled over time, it becomes more like the shagged carpet. This is the precancerous Barrett's esophagus that could turn into cancer over few more years. So what is the relationship between GERD and Barrett's esophagus or esophageal cancer? This graph illustrates the relationship between the duration of GERD and the prevalence of Barrett's esophagus. As you can see, as the duration of GERD increases, the prevalence of Barrett's increases in almost a linear fashion. So if you take patients with reflux for say 1 to 5 years, their chances of having Barrett's is about 10 to 12%. Another way to say that is over their lifetime, patients with GERD, about 10% of them develop Barrett's esophagus, or 1 in 10 patients with GERD have the risk of developing Barrett's esophagus. Why do we care about Barrett's? By the way, this is Dr. Norman Barrett who first described Barrett's esophagus. The disease is named after him. So why do we care about Barrett's? For 3 reasons. 1, Barrett's esophagus is a precancerous lesion for esophageal cancer. I'm going to be repeating this probably another 10 times in today's talk. I want to drive home this point. And number 2, esophageal cancer has a poor prognosis. 5-year survival after getting esophageal cancer is less than 20%. And number 3, the incidence of esophageal cancer has been increasing in recent times. This graph illustrates the incidence of esophageal cancer over time. Esophageal cancer incidence used to be 3.6 million in 1973, and it has increased to 25.6 million per million in 2006. That is almost a 7-fold increase in 3 decades of time. So what is the risk of cancer in Barrett's? Say you have GERD that went on to develop into Barrett's. So what is your risk of getting cancer once you have Barrett's? This is a topic of discussion by itself, and I could lecture on this for an hour. But the short answer is the cancer risk depends on 2 things. 1 is presence or absence of dysplasia. And number 2, depending on the grade of dysplasia or the grade of additional precancerous changes on top of Barrett's, that determines the cancer risk. So overall, it could range anywhere from 0.3 to 7%, but that's more like, that's a broad range across the old diagnosis of Barrett's, and this is not within the scope of discussion for today. Moving to the next question, how do you treat GERD? The treatment of GERD can range anywhere from lifestyle modification to medical or medication options, and then to endoscopic or surgical options or mechanical options. To focus on the lifestyle modifications first, lose weight, that helps with GERD. Stop smoking if you're a smoker. Elevation of the head end of the bed, this could be raising the head end of the bed by 2 or 3 inches, anything helps. Avoid lying down within 3 hours of having your dinner so that the food has a chance to get out of the stomach into the intestine and less chance of it regurgitating into the food pipe. Avoid all the good food that we have spoken about. Again, lifestyle modifications are easier said than done, but it's very effective if followed well. Many patients either try lifestyle modification and find it difficult to follow, or they try them and find that it's helping but not helping enough. Those are patients who go on to try PPI or proton pump inhibitors or the medications of the class as omeprazole or purple pill or Prilosec kind of medicines. There has been recent news about long-term side effects because patients who take these medications often take it for 10 years, 20 years, and sometimes 30 years. And there has been some long-term side effect risks that have made news in recent times. There is a laundry list of potential risks, anywhere from kidney disease, dementia, bone fracture, C. diff infection, pneumonia. Actually, the list goes on. I didn't have enough space to put all the potential risks. But best practice advice based on several GI societies say that these medications are overall safe, but they add some additional recommendations for all the doctors and patients to consider. They include patients with GERD who respond well to short-term PPI use, this could be 2 weeks, 4 weeks, or 8 weeks, should subsequently attempt to stop or reduce the PPI. To put this in practice, say a patient comes to the clinic, I start them on PPI, and then they come back to me later and say that they are feeling great. I shouldn't be telling them, great, you're feeling good, just stay on the medicine. I should say to the patient that, okay, it's good to know that you're responding, but let's try and reduce the dose and see what happens, or stop the medication and see what happens, whether your reflux comes back. If it doesn't come back, then you further cut back the dose or completely stop based on what's happening with your patient. Number 2, patients who try this, reducing the PPI or stopping the PPI and are unable to do that, they should undergo objective testing of acid. Instead of just relying on patients' reported symptom of heartburn, we can also do testing by placing small tubes through the nose and actually measuring the production of acid in the stomach and whether or not it comes up. That way, we don't have to keep treating patients with an entity called functional dyspepsia, where they have the heartburn-like symptoms, but it's not from acid production. So we want to avoid giving PPI medication, especially for 10, 20 years, if they do not have actual acid reflux. Number 3, if patients are at high risk for ulcer-related bleeding from need of using medications broadly called as NSAIDs or Motrin, Aleve, Advil kind of medications because they have rheumatoid arthritis or something like that, it's okay to continue PPI medications on long-term basis. In those patients, the benefits of the medicine, the PPI outweighs the risk comes with it. And sometimes patients come to my clinic and ask, I've tried Prilosec, it works great, but my friend told me that pantoprazole could be safer in terms of side effect compared to omeprazole. Can I switch? The recommendations say that the potential side effect profile or the risk is about the same in this entire class of medicines called PPIs, and the risk of adverse event should not be the reason for switching from one PPI medication to another one. So if you started on a PPI and if it works, you don't have to necessarily change to another one. You should consider if you can stop it or reduce it, don't work on switching. To summarize my talk, this is a sentence I tell almost to all my patients in the esophagus clinic. PPI medications are not candies, though they are available like candies over-the-counter medications. So they are medicines, so they can cause side effects, and we always should weigh the benefits with the risk and decide what's best for patients. Chronic GERD, when it's not monitored or controlled, is a risk factor for developing Barrett's esophagus. Barrett's esophagus is a risk factor for developing esophageal cancer. Treatment of GERD includes lifestyle modifications, and when they don't work, PPI medications. And patients who don't respond to PPI medications or patients who don't want to take the PPI medications for X, Y, or Z reasons should consider endoscopic or surgical options. My colleague Dr. Hupka is going to be talking about these endoscopic and surgical options in the next talk. Thank you.
Good afternoon. My name is Misha Hupka. I'm a thoracic surgeon here at Virginia Mason, and I'm very excited to share some information with you regarding anatomic treatment of gastroesophageal reflux disease and hiatal and paraesophageal hernias. What is gastroesophageal reflux disease? Gastroesophageal reflux disease is when gastric contents, rather than moving forward and downstream towards the small intestine, go backwards into the esophagus. It is a mechanical disorder, and it is associated with some symptoms. Usually when our patients present to us, you present either with symptoms of heartburn or acid regurgitation or retrosternal burning, but also atypical symptoms can be associated with reflux, such as chest pain, inflammation of the voice box, the larynx, chronic cough, and even aspiration pneumonias. And these are very common, especially in our elderly patients. Reflux is a very complicated mechanical problem. It is related to a number of things. One can overproduce acid in their stomach. One can have failure of the flap valve, which resides between the esophagus, which is the swallowing pipe, and the stomach. If you look at the screen, this here is the esophagus. Food makes it down and then enters the stomach. And this mechanism of suppressing reflux is a very complex mechanism, which I'm going to explain to you on this slide. Here on the left side of your screen, you will see the esophagus, so the top of the swallowing tube, or rather the bottom of the swallowing tube, entering the stomach. The musculature of the esophagus changes and forms an area which we refer to as the lower esophageal sphincter. Here is a view of that sphincter looking from the stomach up into the esophagus. So here you can see 5 examples of the esophagogastric junction. Here is a normal anatomic arrangement where you see the esophagus entering the stomach. Here is the muscle, which is called the diaphragm, that divides the chest and the abdomen. And this forms an anti-reflux mechanism. The way it works is that when food enters the stomach, the lower esophageal sphincter constricts and doesn't allow for food to or acid from the stomach to enter the esophagus. However, the stomach also distends by ingestion of food. That in turn accentuates this angle, which we refer to as the angle of His. Now imagine if this mechanism fails for whatever reason, the acid contents of the stomach reflux backwards into the esophagus, and that's why you develop symptoms. Now, the most common reason why this happens is because we form a hiatal or paraesophageal hernia. That means that the top of the stomach, through this area of weakness in the diaphragm, herniates upwards into the chest and the very top of the stomach forms hernia. There are different types of hernias, and we treat them differently depending on the anatomic configuration. Type 1 is a hernia in which the entire top of the stomach herniates upwards. Type 2 is a hernia where the lower esophageal sphincter, or the junction where the esophagus and the stomach meet, is in its original anatomic position, but the stomach herniates near the esophagus or in the paraesophageal space, and forms a little knuckle of the stomach is sitting in the chest. Type 3 is a hernia where both the junction between the esophagus and the stomach and the stomach itself herniate upwards, with the stomach lying adjacent to the esophagus. And type 4 denotes a hernia which contains another organ, such as the small intestine, large intestine, pancreas, spleen, basically another organ in addition to the stomach. And that is the difference between hiatal hernia, which includes this entire group of hernias, and paraesophageal hernia, which is a hernia that has a stomach sitting on the side of the esophagus. When we look at patients who have hiatal or paraesophageal hernias, we always do a number of studies. One of the studies is an upper endoscopy, which many of you have had. Here is a normal view of the endoscope entering the stomach and looking backwards. The endoscope can flex, and even what we call the retroflex, so look backwards, and you can see the endoscope entering the stomach. This is a normal, competent valve. As the valve becomes less competent, there is a space between the endoscope and the fold or the flap valve, which prevents reflux. Here you can see a more severe example, which would be a grade 3 valve, and here a large hiatal hernia where the sphincter is displaced towards the head and the mechanism has been disrupted completely. This classification was described here at Virginia Mason by Dr. Lucius Hill, and is referred to as Hill endoscopic classification of esophagogastric junction valve. The reason why it's important is because the more severely distorted the valve is, the more symptomatic and likely the patient is to reflux. Now, why do we do surgery, or why do we intervene on gastroesophageal reflux disease and hiatal or paraesophageal hernias? When you look at the Society of Gastrointestinal and Endoscopic Surgery, the indications are, or the recommendations of this society, the recommendations are failed medical management. So you are on an antacid or a proton pump inhibitor, you've been on it for years and your symptoms are worsening, or you've been taking increasing doses of these medications and you still have symptoms. That's an indication for intervention. Some people, due to the side effects of medications that Dr. Krishnamurthy listed, are opting for not taking them for a long time. So in that case, because as I noted, it is a mechanical problem and we try to solve it mechanically, people opt for surgery to get off medications. And we'll discuss that, I'm sure, in our question and answer session, and also in some information I'll give you later. And then there are sequelae of gastroesophageal reflux and hiatal or paraesophageal hernias. When the esophagus bathes in acid or bathes in gastric contents, the lining of the esophagus undergoes a change. So it changes from one type of lining to another type of lining. That process is called metaplasia, or change from one type of lining to another under a change in environment, which in this case is acidic environment. And what happens is one gets inflammation in the esophagus, and eventually one can get Barrett's esophagus, which is a change in the type of lining. And even in extreme examples, one can develop precancerous or even cancerous changes in the esophagus. Several times a month, I perform esophagectomies, which is an operation where we have to remove the esophagus, and that is done because a patient has had unmitigated reflux and has formed esophageal cancer as a result of the reflux. In our Western society, The more common esophageal cancer is a cancer called adenocarcinoma, which is in the lower esophagus related to reflux. Worldwide, the most common cancer is squamous cell carcinoma, which is in the upper esophagus and not related to reflux. And so we try to be aggressive and mitigate symptoms and sequelae of reflux if we can. There are extraesophageal manifestations such as lung problems, hoarseness, problems with one's voice box, cough, chest pains. Oftentimes we meet patients who have seen cardiologists, who have had other workups because they have symptoms of chest tightness, and everyone thinks it's from their heart, where it's actually from their either hiatal hernia or paraesophageal hernia or reflux. So when we look at how to mechanically repair reflux, we look at all the structures that are involved, and that are the esophagus, the lower esophageal sphincter, the diaphragmatic crura, which is basically the opening in the diaphragm through which the esophagus passes. It's basically this opening right here that you can see on the slide. And then the phrenoesophageal ligament, which is the tissue which connects the esophagus to the diaphragm, and of course the stomach. And we have to evaluate all those structures and function of those structures so we can make the best decision together with you on how to go about treating your reflux or your paraesophageal or hiatal hernia. So that's the type of studies you would undergo are the upper endoscopy, and I showed you the images of the endoscopy in the preceding slide, but also other studies. The studies are pH study, where we measure the acidity in the esophagus. On the left side of the screen here, you can see a report of such study. We look at when is the pH less than 4, so when is the pH acidic in the esophagus? The esophagus should not have acidic environment. We look at when the patient is upright, when you are supine, and then how many reflux episodes lasting that 5 minutes that you've had, what was the longest episode, and then what was the total fraction of time which was where the environment was acidic. We also correlate the acidic episodes rather to your symptoms. So you always record your symptoms, and then we say, well, when, for example, you were feeling burning under your breastbone, you were having a reflux episode, or you were not having a reflux episode. And all of this gives us an aggregate score called the Demeester score. The normal Demeester score is less than 14.7. And obviously in this patient example, the Demeester score is very elevated at 79, which is not uncommon. And this patient also has very good correlation. Here you can see symptom index and symptom associated probability. He or she were having chest pain, and all the episodes of chest pain were related to reflux. So that we can tell you that, hey, if we fix your hernia or fix your reflux, your symptoms of chest pain should get better. If the correlation is not perfect, then we say, well, we can fix your reflux or fix the hernia, but the symptoms you're having must be due to something else. So even though your reflux will get better, the symptoms are unlikely to improve. We also need to make sure that when we repair the hernia or build a flap valve for reflux, that we don't make the repair too tight, because not everyone's esophagus functions normally. Esophagus, as I mentioned on the slides before, is a muscular tube which carries the food from the mouth to the stomach. Its job, like a toothpaste, is to squeeze food down the stomach. That is called a peristalsis. So every time a person swallows, there's a wave of muscle that contracts downward on the esophagus and propulses the food down into the stomach. And we look at 10 swallows, and then we measure the amplitude of the peristaltic contractions and make sure that they are coordinated and that the esophagus is working normally. In up to 30% of patients, the esophagus does not work normally. It is either weak or the waves are not coordinated or failed. And so that means that when we build a flap valve, we don't want to make the flap valve so robust or so tight that it will replace one problem, which is reflux, for another problem, which is a problem with swallowing. The other study you will always get, and many of you may have had, is a study called esophagram. Esophagram is third here on the list, so upper endoscopy, pH study we talked about manometry. Esophagram, you can see the top of your right-hand screen is a study where a patient ingests barium, and we take X-ray films of the swallowing and look at, here you can see the stomach, and this is the part of the stomach that resides in the abdomen, and you can see a narrow neck of the hernia and the stomach that's herniated up into the chest to give us a gauge of the size of the hernia. And our radiologists who are very experienced doing these studies will also put you through various provocative maneuvers where you lie on your abdomen, where they have you raise your legs to see whether we can not only passively observe reflux, but actively, provocatively instill reflux to simulate a real situation when you're eating at home and perhaps sit down with tight pants, which pushes on the abdomen and then produces reflux. Or many people, I saw several people in my clinic today who like to garden, and every time they bend over gardening, they develop acidic symptoms and food or stomach contents coming up. Another study we get is a CT scan in select patients because we want to look at not only the anatomy of the esophagus and the stomach, but the other anatomy as well to make sure that we don't miss anything. And here you can see in the lower part of your right screen, here is the liver, here is the spleen, here are the kidneys, here is the aorta, and here is the heart. And behind the heart, near the aorta, there is the esophagus, which you cannot see in this image, but it comes down. And here you can see the stomach that has herniated up into the chest. And in select patients such as diabetic, if you're a diabetic, we make sure that we also check the function of the stomach by something called a gastric emptying study. That is a study that takes 4 hours, and you ingest a radio-labeled, usually egg sandwich, and then we take pictures at 1 hour, 2 hours, and 4 hours, and look at normal values and make sure that your stomach is emptying normally and propelling food downstream normally, so that when we build you a flap valve, we don't overdistend the stomach and have the operation fail. And then there are other aspects of your function that we have to sometimes evaluate, such as lung function tests, because imagine if you have a very large hernia that's occupying a large part of your chest, it pushes on the lung and pushes on the heart, so those organs can be impaired as well. And oftentimes people can present with shortness of breath, and when we repair their hernia, they feel much better and they can keep up with their spouse. So how do we choose what to do? Well, we take all the studies that I just listed, which can take 1, 2, or sometimes even 3 visits to the hospital, and we discuss the results with you, and then we decide on what to do. In some select patients, we can treat reflux endoscopically, and in some patients, in majority of patients, that is, we have to treat it surgically. Surgery now is mainly robotic surgery, where we use very small incisions and the robotic system, and use these small wristed instruments inside of you to repair the hernia or to build you a new flap valve. But in some cases with giant hernias, those type 4 hernias that contain other organs, we still rarely employ open operations. Then here you can see these various names that if you Google things on the internet, you'll see Nissen fundoplication, Toupet fundoplication, Dor fundoplication. These are just different degrees of fundoplication which we tailor to your needs, because if your esophageal function is imperfect, we don't want to do a 360-degree, the standard Nissen fundoplication. We want to build a flap valve which will prevent your reflux, but also continue to allow you to swallow. Oftentimes you will see on the internet that up to 25% of patients who have these types of operations develop symptoms of gastric bloat or trouble swallowing. And it is true, some people have a hard time belching. And some people, when you like to eat certain foods like dry chicken breast, dry bread, or peppers, those things can stick after an operation like this. It's kind of like if you have a knee replacement, you have to learn a new way how to walk, how to ski, how to do the things you like to do. Similarly, after an operation like this, your life should be better, but there's a new way of eating. It's better to eat slower, chew well, take a little sips afterwards, and those are all things we talk about in clinic. And then there are other adjuncts, because especially with large hernias, these hernias, the reason why they happen is because the environment in the chest is negative. Every time we breathe in, we're sucking air into our lungs, but we're also sucking everything into the chest, especially through the esophageal hiatus. And the pressure in the abdomen is positive. So everything wants to go down the pressure gradient from positive pressure to negative pressure. And so we try to sometimes anchor the esophagus, anchor the repair. Some centers, not ours, use various prostheses such as mesh. We are very much against the use of mesh because it can cause problems. And some of the revisional operations we do that were done elsewhere, we oftentimes end up explanting the mesh that we put around the esophagus because it can erode stricture. It can cause problems, but in the world of surgery, those are the adjuncts that have been employed to help with repair of these hernias. And so there are certain principles that we have to adhere to. One is that the hernia always drags in a lining of your intestinal and abdominal cavity, and that is called the peritoneum. And so that is called a hernia sac, that this peritoneum, which has bulged up into the chest, forms. And we have to mobilize, reduce, and resect that sac to form scar tissue in the chest so that the hernia does not recur. Then we need to free up the area around the diaphragm to make sure that we have nicely mobilized and freed up muscles that we can close and repair the hole in the diaphragm. And then we have to be very careful of these two nerves, which are called vagus nerves, and then travel on each side, on the front and back of the esophagus, so that we don't injure them, because those nerves make the stomach contract. And so if both nerves are divided, which has never happened to us, but we've done plenty of operations in which the stomach, after someone else did surgery and the stomach did not work, then that can be a problem because it will result in bloating of the stomach, and the stomach doesn't function normally. And then we obviously repair the hole in the diaphragm, and then we do a tailored flap valve. And here you can see, here are the examples that I noted here on the previous slide with a Nissen Toupet door. Here you can see a Nissen fundoplication, which is a 360-degree repair. Here you can see a Toupet fundoplication, which is a 270-degree repair. And here is a 180-degree front repair called a door repair. And we choose based on your anatomy and the function of the esophagus on how we rebuild this flap valve to prevent reflux, either with or without repair of your hiatal or paraesophageal hernia. Here is a repair which we reserve for very large hernias. Here is an example of a chest x-ray of a patient, and you can see that there is an air fluid level because the stomach is herniated into the chest. It's filled with fluid, and there's an air bubble sitting right here. And it's a repair where we actually wrap the stomach around the esophagus and anchor it with sutures, sew it down to the muscles, which are some of the muscles of the diaphragm. And this is a very durable repair, which is very low recurrence rate. And there is still, it's a historical repair, but we still use it because especially patients, I just operated on a patient who is a retired physician, and he's very active. He's a sailor and a skier who are very active with a lot of impact into the abdomen and had a very large hernia. It's an extremely durable repair that provides us with a very solid anchor type situation long term. Now, there are other techniques, more modern techniques, which we utilize in select patients. On the left of your screen, you can see this is for treatment of reflux for patients who have hernias less than 3 centimeters, and it's called a LINX system. It's basically an artificial sphincter which is inserted around the intra-abdominal esophagus and opens up when the patient swallows and closes off when the food passes through. We don't use this technique. The reason is because there have been a number of case reports in the literature which have failures of the system by scar tissue eroding into structures. It's just like mesh. The esophagus does not like to have foreign bodies around it. But we do for patients with hernias less than 2 centimeters, we do a procedure called transoral incisionless fundoplication. This is a procedure that allows us to go without incisions with an endoscope through the mouth and then insert a device into the stomach through the esophagus, which retroflexes or flexes backwards and plicates or fuses the stomach with the esophagus and builds a new flap valve, which is a 270-degree, 3 centimeter long flap valve. And that procedure has excellent results. About 60% of patients at 5 years are able to be off of any antacids, and 86% of patients in 5 years have markedly improved symptoms of reflux. In the largest trial called the TEMPO trial evaluating this technology, in our experience, we have done over 70 patients at Virginia Mason with this technique, and I would say that it's worked extremely well. It failed 3 patients I had to reoperate on for various reasons. Usually it was because the hernia was larger than we appreciated procedurally, but most patients are extremely happy, and it can be done on outpatient basis. 4 out of 5 patients go home the same day with a procedure like this. So gastroesophageal reflux disease and hiatal and paraesophageal hernias are a very complex anatomical problem which requires multidisciplinary management by experienced gastroenterology team, thoracic surgery team, requires a complete workup, a shared decision-making with the patient and their family to understand the recovery in the context of the rest of their life. And this is the algorithm we use at Virginia Mason. If someone has gastroesophageal reflux disease and they're on medical therapy, if the medical therapy becomes ineffective, then we evaluate you. And if the evaluation shows, the evaluation includes your upper endoscopy, evaluation of the esophagus, the acidity, the swallow study with the barium, and a CT scan. If the hiatal hernia is small and the patient has reflux, then we can do endoscopic therapy. If the hiatal hernia is larger or there is a paraesophageal component, again remember that the stomach goes on the side of the esophagus, then we can do robotic repair with a fundoplication, which depends on your esophageal function. If the hiatal hernia or paraesophageal hernia is huge, if you have colon in your chest, the entire stomach up in the chest, then we oftentimes do an open repair. If any of these fail, then we move on to the next step in the operative or procedural sequence of repair. If someone the medical therapy works and the patient is not interested in stopping medical therapy or not interested in continuing medical therapy for decades, then we proceed with the workup, with the manometry and upper endoscopy, and move down this pathway. So thank you very much for your attention. I know that you are supposed to watch this video just before our discussion, and I'm excited to answer any questions. Thank you.